For the doctor who loves physiology and hemodynamics and flow, this will be his climax and thrill. The VA ECMO. The VV ECMO is very simple. The VA ECMO is where you're going to look at the interaction between the opposing force of VA ECMO and the force of the native cardiac muscle itself. And not only that, the interaction between the pulmonary cardiac components and the ventricular arterial components. So it's a very complex physiology. I don't want you to concentrate on it. As I said before, when it comes to a VA ECMO, we will take it slowly and we will do it with perfection, beautiful understanding of physiology and hemodynamics of the heart. And we will be experts in echocardiography when we come and assess hemodynamics. The difference between cardiologists and people who like ICU, whether they are from medical background, anesthesia, surgery, whatever they are, they look into structures, we look into function. That is the difference. We look function, flow, hemodynamics. How is the heart interacting with the lung? How is the heart interacting with the vasculature? How is the heart interacting with the surrounding? They look at diastolic dysfunction. They look at valvular disease as structure. They look at walls that are not moving. Walls that are not moving are of importance to us, but what is more important to us is this wall that's not moving generating enough pressure to overcome the outflow resistance and generate good VTI to support the circulation or not. That is what's important for me. If the car is damaged, but it's still running, it's fine. No problem. That's what I want. I don't want you to tell me that EF is 20%. I want you to tell me that EF is 20% and my VTI is okay. It's 14 and 16. But you give me a 20% and a VTI of 9, that's very bad. Okay? Now, we have policies of VV ECMO that tells you exactly what to do, how to run things, how to check every day certain things. And these checklists are going to be the job of the ECMO specialist. Whoever is the ECMO specialist, nurse, perfusionist, RT, porter, whoever is it, is the ECMO specialist. His job in the morning or each shift that takes over is to do the checklist. Okay, I'm done, Victoria. So this is the checklist. And thank you very much.
That's great. Thank you very much, Dr. Shamsa. Actually, very good time management. So I might actually do my presentation now that we have time, because it's not going to take long. I'll probably spend 15 minutes. And it's on the cannulation. If you can stop sharing your screen, please, Dr. Shamsa, and I can start sharing mine. Oops. You are screen sharing, so can you see my slides? Slideshow. Yep. Can you see it?
Yes, doctor, we can see it. It's clear.
Okay, good. Thank you very much. This is actually Dr. Ahmed Hani's lecture, so I'm doing it on his behalf. So excuse me if I'm not familiar with the order of the slides, but he's working very hard this weekend as he's on call. So I'm just going to spend the next 15 minutes or so talking about cannulation. Again, no conflicts of interest that I have. And the objectives of this lecture is to look at the different types of ECMO cannulas that are available and how to select the appropriate cannula size and type, recognize the access and return vessels that you will target, and recognize the different cannulation techniques, know the steps for cannulation and the tools for guidance and confirmation of the cannula placement, and also finally know the steps for decannulation. So with regards to the types of cannula, we mentioned earlier the, sorry, just, okay. We mentioned earlier that we have either the single cannula or the double lumen cannula. Single cannula we use in the femoral jugular configuration, and the double lumen cannula we use through the internal jugular cannulation. So this is a picture of your single cannulas, and you can see here they are color coded. So the venous cannula tend to be blue in color, while the arterial cannulas are red in color. The difference between the venous and the arterial, we say venous and arterial referring to your access cannula and your return cannula. So your access cannula is your venous cannula, and your return cannula is your arterial cannula. Remember that return cannula EV ECMO is actually in a vein, but it might be one of these red colors. So it's because it's return, that's why we say it's red. The access cannula tends to be a longer cannula compared to the return cannula if you're doing the femoral-jugular configuration. The access cannula also has multiple holes in it. If you can see here, you can see several holes alongside the cannula compared to the return cannula, which tends to have only a single hole at the end here. And the reason we have multiple holes is to maximize the drainage of your cannula. Remember, your access cannula is where your blood is coming, and this is what's going to determine your blood flow or your ECMO flow. So the more holes there are, the more flow that will come through it, and the better your ECMO flow. In your return cannula, all what you need to do is to return that blood into the right side of the heart. So that cannula tends to sit at the junction of the IVC, SVC, and the right atrium. So you cannot have multiple holes in it, because if you think about it, if you holes here and you're returning your oxygen, then all this nice job that you're doing with the ECMO will be leaking out earlier. So what you want is that oxygenated blood to come straight out of the cannula at the tip here, straight into the right side of the heart. And hence we're using the short cannula for that with a single hole. Now, there are some configurations where they do a femoral cannulation. So you can have your access cannula in the femoral vein, and you can have your return cannula also in the other femoral vein. But the return cannula, again, will have to be a single hole. You cannot have it with multiple holes for the reasons I mentioned earlier. And it then tends to be a longer cannula than your access cannula, so that your tip will be sitting at the right atrial junction. But we don't use that in Kuwait. We might be starting to use it soon, because there will be some indications for certain patients. The commonest one that you will come across is the femoral-jugular cannulation route when we're using a single cannula technique. So this is for your access and return cannula and the single cannula. The other type is your double lumen cannula, which you can see here. So it's like your double lumen tube. It's two tubes combined together, and then they'll be diverting here, and one of them your access cannula, where it's draining the blood out, and the other one is the return cannula, where it's bringing the blood back into the patient. And I've got another figure later on, which I'll show you where that cannula actually sits in the heart and in the IVC and SVC. The advantage of this cannula, we mentioned earlier, somebody was asking the question, is that it allows mobilization of the patient because it's a single line in the neck and the rest of the body is free. It's very good for obese patients because you have a single hole, and you don't have to worry about two punctures, so it's only one puncture, but it needs a certain expertise in placing it and imaging as well. Okay, so how to determine the cannula size? What we do is we echo, we do ultrasound anyway. All our cannulation is done percutaneously through the Seldinger technique, and we use ultrasound guidance like you would for any central venous cannulation. So we look with an ultrasound at the vessel that we're going to cannulate. So if we're going to go for access in the femoral vein, then we look at the femoral vein and we look at the diameter. And then the size usually is, we look at the diameter of the vessel in millimeters, and then we multiply that by 3. the French size, remember, is 0.3 millimeters. So 1 millimeter is 3 French. So if you multiply the diameter of the vessel by 3, then you get the French size, which is the maximum French size that would accommodate that vessel. So if you got, for example, a diameter of 7 millimeters, then you'd be inserting maximum 27 French size in that vessel. The body size, the age, and the site of cannulation also factors. The drainage cannula, as we mentioned earlier, is a bigger size cannula than your return. Usually we use sizes between 25 and 26 French. The return cannula is a smaller size. However, it's still big in the VV ECMO, so it's anything ranging between 21 and 23 French. If you're using VA ECMO, then your return cannula obviously has to be smaller than your return cannula in the VV ECMO, because as Dr. Shamsam mentioned, you're inserting it in an artery, not a vein, and therefore you don't want to be expanding that vessel and causing it to rupture by putting big cannulas and having high pressure. So we tend to go between 15 and 17 French for the return arterial cannula. For the reperfusion cannula, which is the cannula that I mentioned, you put in the femoral artery antegrade against the direction of your femoral return cannula in the VA ECMO in order to perfuse the where the cannula is placed, is a smaller cannula between 6 and 8 French. I'll show you pictures in a minute about that. Okay, so this is, again, as I mentioned, it's ultrasound guided technique when you're doing the cannulation to look at the vessel, to look at the diameter. So you've got your femoral artery and femoral vein there, and then you do the cannulation accordingly. So your drainage cannula or your access cannula has to be sitting into the hepatic vein level, as mentioned earlier, just below the hepatic vein, while your return cannula will have to be sitting at the junction between the right atrium and the SVC IVC. So this is a picture of your femoral jugular approach. So here you are, your access cannula in the femoral vein, going through the pump into the oxygenator. Oxygen is added, CO2 is removed, and then the oxygenated blood is coming back into the patient return cannula, which is red here, although it's VV ECMO, but because it's returned, then it's red, and it's driving the oxygenated blood back into the right side of the heart. So that cannula should be sitting here at the right atrial junction. Your access cannula has to be at the hepatic level, and there should be a distance between your access and your return cannula, as mentioned earlier by Dr. Shamsa. If they're too close, then what's going to happen is that lovely oxygenated blood that you're going to inject back into the patient is going to be sucked by your access cannula, and it will be returned back into the ECMO circuit. So this is what we call recirculation. So all your good job is being sucked away by the ECMO, and that's what you don't want. So what you do is you pull your cannula down a little bit so that you have a 10 centimeter distance between the two cannulas to prevent the phenomenon called recirculation. This is the femoral approach. I mentioned earlier, where you can do VV ECMO through access in the femoral vein from one side and return in the femoral vein from the other side. And the two cannulas will be sitting alongside each other with 10 centimeter distance between them again. So the access has to sit at the hepatic level and you return at the right atrial junction level. You can see here the distance between them. And again, your access cannula is the multi-hole one, while your return has to be a single hole one with no holes here. Otherwise, you will be sucking the blood that's oxygenated. You will be sucking the blood that's oxygenated by injecting it quite proximal to the end of the tip there. VA ECMO, so you've got your access in the femoral vein. draining the venous blood through the pump into the oxygenator and returning it back into the patient. And this is for circulatory support, so we have to return it into the arterial system, so back into the femoral artery using a smaller cannula and sitting somewhere in the aorta there. The access cannula position in the VA ECMO is the same as the VV ECMO, so it has to be at the hepatic level or the hepatic IVC. So this is a picture of a VA ECMO where you can see, your access cannula and your return cannula, and this is your reperfusion cannula, which is going antegrade. Which is going antegrade. Okay, so what it's doing is that you're taking, once you've oxygenated the blood, you're taking part of the oxygenated blood through the tubings here, which goes through the reperfusion cannula and provides the oxygenated blood to the distal limb, while this cannula here is going upward retrogradely into the systemic circulation, and that's your access cannula. The double lumen cannulation, we've got a picture here. So that's your cannula here. So you can see it's double lumen and it's got 3 holes here, one proximal and one distal and one in the middle. The proximal and the distal holes are the drainage holes. So they drain blood from the SVC, from the IVC, and the SVC out of the patient, and then it goes into the ECMO machine and returns oxygenated blood through the middle hole. And this middle hole has to be sitting against the tricuspid valve so that all the oxygenated blood will be directed immediately into the right side of the heart by sitting against it. So if that position is changed, just a slight change, if you think about it, if that cannula is rotated where this hole is facing outward, then you will be getting recirculation and you will not provide optimal flow. So you can see it here again. So that's your tricuspid valve. This is your distal hole. This is your proximal hole, taking blood out, while this is your return hole in the middle, putting the oxygen blood back into the patient. Okay, so very good cannula, but it needs to be in the right position. Sorry, need to get rid of this top. I cannot see the slide title. Okay, we'll move on, I think. I cannot see the slide title, sorry. How do I get rid of this? That's it, it's gone. Good. Okay, let's go back. Okay, hybrid ECMO. Okay, so this is hybrid ECMO. It's when we're actually combining VV with VA ECMO. So sometimes we'll talk about the other lectures talking about complications, what might happen with VA ECMO. If you're on VA ECMO and you develop respiratory failure, then you might need to be also on VV ECMO. So you'll be converting from VA ECMO into VAV. And at the same time, if you're on VV ECMO for respiratory failure and then you developed cardiac failure, then you might also need to add an arterial limb, and therefore you will go from VVA. So this is your hybrid ECMO. So your VVA, so your access will be in the vein and then you return into the vein, but also you will be getting another return cannula into the artery as well, providing both circulatory and respiratory support. And this is the other way around. So if you're on VA ECMO and then you provide an extra limb to the venous system, providing VAV. Okay, so cannulation techniques. In the past, when ECMO was in the cardiac theater, the main mode of cannulation was central ECMO, like you do in the bypass surgery, through the aorta and the right atrium. So your access cannula will be in the right atrium, draining the blood back, and your return cannula will be in the aorta, pushing that oxygenated blood back into the patient. Within the intensive care unit, we tend to use the peripheral cannulation technique through percutaneous cannulation or salvager technique, which you're all familiar with, the same as the central line placement. You go through guide wire placement and then serial dilatation till you get your cannula in. If we face difficulty through the percutaneous route, then we do the open technique or cut down, which is done by our vascular colleagues. However, we luckily haven't faced much of that so far in our center, and most of the time we do achieve it with percutaneous technique. How to cannulate this step? As Dr. Shamsam mentioned, the sterility is very, very important. Before cannulation, obviously you need to take your consent and discuss all the complications with the patient and obtain blood transfusions in case you have bleeding or the patient's hemoglobin drops. And you need to get your ultrasound to identify your vascular access. Complete aseptic technique, so you wear your full scrub mask, gown, cap, etc. You drape the patient fully. We use the full body drape when we're doing the cannulation because we use quite long guide wires, and these guide wires can touch everywhere. So you want to make sure the whole field is sterile and that guide wire is well protected, because it's one of the most important parts that should stay sterile because it's going inside the body and the vessel. Try and get a new entry point, a fresh skin basically, rather than a place that has been touched several times. So you do salvage technique, go with your needle, and then you use a super stiff guide wire to make sure that it doesn't bend when you're doing the serial dilatation over it. And then we use ultrasound or fluoroscopy if you have it available. We tend to use ultrasound in our center in order to identify where the tip of the guide wire is and where it's going. If you have echocardiography, it's even better to see where the guide wire is to confirm the position. Then you do serial dilatation over that guide wire using dilators. We tend to go for the dilator size that's one size above the cannula size if it's available. So if you're putting a 22 French cannula, then you need to go to dilate up to a size 23 if it's available, but sometimes you don't have dilators available, and then you just have to do with what you have. Then after you do serial dilatation, you insert your cannula and you aspirate and flush the line with heparinite saline, and then you clamp your line and you connect the end to the circuit, ensuring that there is no air inserted. As I mentioned, you have to have some kind of imaging to guide you when you're doing the cannulation, whether it's fluoroscopy, ultrasound, echocardiography, whether it's transthoracic or transesophageal echo. And also after insertion, you need to re-image to make sure that where the cannula is. And you do CT, obviously, afterwards, just to ensure the position and also the location of the tips of the cannula, as well as X-ray. You can see that there. The cannula is. So decannulation, patient is improved and they're recovered, then you need to prepare for decannulation. And for that, you need to prepare adequate amount of blood. Again, the same as for insertion. You need to stop the heparin to avoid bleeding. And you do it also in an aseptic technique in the same way that you have inserted it. We use a purse string suture, which is like a string around the cannula, so that once the cannula is taken or removed, then you can just close the skin around the hole where the cannula was. And we do that all in the intensive care unit. So we clamp and keep the cannula side dependent. We make sure that there is no air coming in when you're removing the cannula. After decannulation, we do ultrasound of the vessel that was involved in the cannulation to make sure that there is no thrombosis, because if they do have thrombosis, they do tend to have thrombosis, then they need to be left on anticoagulation for 3 months post decannulation. So that's all what I want to say about cannulation and decannulation. And I think we've covered enough today, from starting from history and background of ECMO, indications, contraindications, the ECMO machine, the equipment involved, cannulation for ECMO and going on ECMO, management on ECMO, and coming off ECMO. And that's the end of today. And I think we're gonna start the discussion for the last session now. Thank you very much. So Mustafa, if we can start the discussion.
There are no questions yet.
Okay, so please, the audience, whoever is there, if you have any questions, I think I saw some questions during the presentation. I'm not sure where they were, whether they were in the chat or I saw some things popping up. Let's have a look.
Is this a new question? When this one, the last one from Kalpana Krishnan?
Yes. So when a patient is on ECMO extubated, is it okay to keep the patient on high flow nasal cannula with a FiO2 100% and flow of 40 liters? Okay, I'll let Dr. Shamsa answer this because I keep mentioning this all the time in the unit.
Now, it depends. Okay. Back again to the thing. What is the acceptable saturation that you want? If you see that your patient is on 100% FiO2 with 40 liters, and he's satting 85, and you go down to, let's say, 60% on 30 liters, and he's still satting 85 or 80, let's say 82. That means that your high flow is not putting much into the oxygenation of this patient. Okay, that's what you need to do. Now, this question is a very interesting question because what we look at it is at FiO2 or PF ratio, okay, which is the PaO2 over FiO2. But if you look at the alveolar equation, I wish I can write on this computer. I cannot write on this computer, but let me do it some way where, okay. If you look at the alveolar equation.
There is a whiteboard, Dr. Shamsa, whiteboard. In the screen share, there is whiteboard if you want to write something.
What is whiteboard? Where is it?
When you go to screen sharing option, you will see whiteboard over there. And then you can save it also.
Oh, whiteboard, there is. Press on share screen and you'll see. Yes.
Okay.
Very nice.
So if you look at the alveolar, so how do I?
Yes, it's right now.
Like this?
I think you need your iPad there, Dr. Shamsa.
Okay, forget it. Forget it. Okay, no, let me do it this way, okay? So PaO2, alveolar O2 equals PiO2, what is it? Why it's not there? PiO2 multiplied by barometric pressure minus vapor pressure, okay? This is between brackets. Let me just do it right. I just write the equation so everybody can see it. Minus CO2. Okay, this is the alveolar equation. Basically, what the alveolar equation says, it says that your PaO2, which is the alveolar oxygen, is determined by the amount of inspired oxygen multiplied by the barometric pressure minus the vapor pressure minus CO2 divided by R. And this PaO2 should equal your PaO2, which is the arterial oxygenation, correct? But it is affected by your CO2 and your R. So if your CO2 is high, what's going to happen to your PaO2? It's going to be low. But we are looking at the PF ratio. We're looking at the amount of inspired oxygen to the amount of arterial oxygenation. When so many factors are playing a role in the alveolar oxygenation itself. So if this Barometric pressure is high, it's going to increase this. And if this is low, it's going to decrease this. And if the CO2 is high, it's going to decrease this. And if the CO2 is low, it's going to increase this. And if the respiratory quotient is high, it's going to decrease this, it's going to increase the PaO2. And if it's low, the same thing. So many factors play a role in the PaO2. In other words, what I want to say, we should not be using the PF ratio, the inspired oxygen, saying inspired oxygen is that much and the PF ratio is low. We should be using this PaO2 over PA arterial O2, which is going to give you the, if in other words, the alveolar arterial gradient. That's what we should be using. Back to your question. So when you look at a patient, you need to set your goals. What is your oxygenation that you like? If it's 85 and the FiO2 is not helping that much on the lung, you come down with the FiO2. If it's 85 and if you come down on the FiO2 on the high flow and you see it drops from 85 to 60, no, go back up again, because you want the patient to be breathing spontaneously. That's what you want.
Yeah.
Did I answer?
Yes, yeah, and I think it's important. I think it's a good question, because you do see that some people, when they're on the ventilator, we always go on rest settings where we put them on 40–50% of FiO2 with low driving pressure and low tidal volume, etc. When they're extubated and they're on the high flow, it should follow the same principle. So you should go on the rest setting with lower FiO2, around 50%. And for me, the useful thing about it as well, provided you've got adequate saturation of 85% plus, is that once you start to see recovery in the lung, you will see an improvement in the saturation. And you need to keep your trends or your settings constant. You don't want to be changing a lot, so that if you see a change, then it will reflect an improvement in the lung rather than you changing the parameters. So provided that you have adequate saturation, and by adequate saturation, I mean 85%, because some people find it very uncomfortable to see saturations of less than 90 on patients. But for ECMO patients, for patients with severe ARDS, this is acceptable. Saturation 80, 85, this is absolutely fine. And that's our aim, because we want to rest the lungs, so we will compromise with that and put them on lower ventilatory setting, including the FiO2. Keep that constant as much as you can. Keep them on the ECMO, rest them till they start to improve. And then you will start to see the improvement both in the saturation, in the lung compliance, and in the tidal volume, etc. So, and the same thing, there's another question about what range of lung compliance is best to decannulate from VV ECMO. So it's the same thing. You're looking at the trend. So it's not a single number that we look at. You look at the trends of the patient and a constant improvement in their parameters, constant improving the saturation, constant improvement in the compliance, and constant improvement in their CO2 clearance, etc. Okay, but it will be the same. Usually you'd have very, very low compliance, sometimes 1 or 2 compliance, sometimes you have no lung at all, and then you start to improve, going to 5, 10, 15, 20, then you know that they're starting to get better. So another question, what is the most appropriate site for ABG sampling to measure SpO2 in determining recirculation phenomenon? So, Dr. Shamsa?
It's obviously the best site is pre-membrane. That's what you need. There is a port pre-membrane. You measure the oxygenation there, and there is an equation for recirculation, which I don't. I have a very bad memory in memorizing things. There's an equation, you can plug it in, and it gives you the amount of recirculation, whether it's 10, 15, 20%. But it's pre-membrane. That's what you need. Pre-membrane saturation. The other machine, the Xenius machine, the McKay machine, CardioHelp, has a saturation probe on the pre-membrane limb, and it will tell you how much is the saturation there. Yeah. So if you run ECMO and you see that your pre-membrane saturation is 85 and 90, that means either the heart has a very low cardiac output and you're recirculating so much through it, okay? Or your cannulas are too close to each other and you're running high flow and you're recirculating so much. Or the third thing, there is not much oxygen utilization by the tissue and your blood coming back having a high mixed venous saturation. 3 things. Okay.
Okay. So there's another question there. Does ECMO patient require for anticoagulation drug?
Yes.
I assume you mean, does the patient needs to be anticoagulated? So the answer, yes. We anticoagulate everybody who's on ECMO unless there is contraindication to anticoagulation, like bleeding, intracerebral hemorrhage, etc. So another question, is it mandatory to do CT brain before starting ECMO, especially if the patient is unstable to do CT?
No.
So the CT, the CT is actually after cannulation. What we do once we put the patient on ECMO and they're stable, because they should be stabilized, the ECMO is what stabilizes them, then we take them for CT, brain, chest, and abdomen. And the reason for that, you want to know what their baseline CT is, because some patients might have intracerebral hemorrhage as a start, and you don't know if you haven't done it from the start, whether you have caused it later on by your anticoagulation, whether it's actually been there from the start. That's one thing. And the other thing, if they do have intracerebral hemorrhage, then that means you will not be anticoagulating them. So that's the 2 main reasons we do that. For the CT chest, we want it because we want to see what their lung pathology is like, and as a baseline again, so that if they improve or worsen later on, then we have a baseline CT. For the abdominal CT, then we do that to exclude any intra-abdominal hemorrhage secondary to the cannulation.
There is one other question, Laura.
Yeah.
What is the best compliance to decannulate from VV ECMO? There is no magic number for compliance. When we extubate somebody, do we check compliance? No, we don't. We look at blood gases, we look at shallow breathing index, we look at tidal volume, we look at minute ventilation, we look at inspiratory pressure in certain circumstances. We don't look, and we look at the CNS function of the patient and we extubate that patient. Decannulation of ECMO is the same thing. If you think that this patient if you think that this patient would be easily handled by the ventilator with moderate to minor parameters, then don't go ahead and decannulate the patient. But ideally, you need a compliance above 30. But a lot of patients will have a very high compliance, yet they have VQ mismatch with a lot of dead space, like PE, for example, widespread PE. And we see a lot of COVID patients. We have one patient in bed 18. He has a wonderful compliance, but his CO2 is sky high and his oxygenation is fine. We put him in CO2 removal now after we took him off ECMO. He takes a tidal volume almost like 600 and 700. His compliance is always above 30, but his gas exchange is very bad because he's got a lot of dead space. So compliance is only for the stiff lung, but the compliant lung with bad gas exchange, that is a problem. And that takes us back to the point that I mentioned before. I think we need to change our way of looking at hypoxemia. We should look at the AA gradient and see if we challenge this lung with FiO2, would the AA gradient decrease or stay the same? If the AA gradient decreases, that means that these are alveoli that are open, and all you need is a little bit of FiO2 into them to increase the PaO2 according to the alveolar equation, which means that some recruitment will help. But if the AA gradient does not increase, it means that you have a lot of shunt. You've got blood that is deoxygenated going through alveoli that are closed, and putting more oxygen into those alveoli is not going to open them. And also you're going to try to recruit to see if you're going to open these lungs. But it will tell you whether you have VQ mismatch because you have small airways that still are ventilated. All you need is a higher FiO2 to increase the PaO2, or it will tell you it is mainly shunt that's taken place and a lot of consolidation, and good luck with opening these lungs up.
Mm-hmm. There's a question about HIT positive to tomorrow Omar is going to tell us about anticoagulation ECMO. So what is the drug of choice for anticoagulation on ECMO? If the
Bilvirudin.
patient is H positive?
It's bilvirudin.
Yeah, bilvirudin.
All of
Okay.
one of them, either fondaparinux or bilvirudin.
Another question, is compartment syndrome due to cannulation a contraindication or a reason to remove cannula or cannulate to a different site? So if basically if you develop compartment syndrome, I assume they mean in VA ECMO, if you have compartment syndrome secondary to the arterial cannula and the return, then will that be an indication to remove the cannula?
Maybe
Put it somewhere else.
abdominal compartment.
Is it? I don't know if they meant abdominal compartment or if they meant compartment syndrome in the leg.
If you have an abdominal compartment syndrome, the treatment is basically to open the abdomen. Okay. But if the compartment syndrome is due to cannulation, a contraindication or reason to remove the cannula. You never get a compartment syndrome due to cannulation unless you puncture a big vessel there and you cause all the blood to bleed into the abdomen, and then you will not be able to flow. And in either way, you're going to take the patient to the operating room to fix it. Now, if you get an increase in abdominal pressure because of a retroperitoneal bleed that reflects into the abdominal pressure, you will see that your cannula will not be as efficient as before. And you need to have a higher volume for this cannula. And you have to stop the bleeding somehow by interventional radiology or by correcting the coagulopathy that the patient has. But you never remove because of retroperitoneal bleed. You remove only if it's a surgical, iatrogenic, cannula precipitated problem. But whenever you have compartment, you're going to have problems with flow.
Mm-hmm. I'm not sure if they also meant in the arterial cannula also in the leg, but usually what you tend to get if you got hypoperfusion in the limb, you start to get blisters and you got, cold limb. What we need to do then is to get the vascular surgeon to improve the perfusion to that limb by repositioning the reperfusion cannula, doing a cut down, and that tends to kind of improve the problem. Another question, what is the criteria of weaning off ventilator and spontaneous breathing and keeping on ECMO?
Very good question. Very good question. I wish I know the answer, but let me tell you how things have been moving in the ECMO world. So they said, let's stress the lung and put them on ECMO, but keep them ventilated. And then they said, let's ultra ventilate them. First of all, protective ventilation, and then we do ultra protective ventilation. And then they said, come on, let's extubate them early and mobilize them. If you dig the literature, you will find out that a lot of places might have adopted one way or another in terms of weaning a patient of ECMO, whether to extubate them early and put them on ECMO, spontaneously breathing and exercise them, or keep them on the ventilator with ultra protective ventilation or protective ventilation. Which one is more superior? We don't know. We are ourselves finding now that if we manage to get away with spontaneous breathing in the COVID population with less lines inserted, so we minimize the infection and we keep them going with physiotherapy, they do better than if they are on a ventilator with sedation, muscle relaxation, myopathy, diaphragmatic fatigue, and all the consequences of keeping them asleep with a tube or a tracheostomy. Which one is superior? Yet to see a randomized controlled trial to look at the difference between the two. You can be the first one to do it if you want in Farwaniya, comparing patients who are immediately like the patient you have now extubated with a saturation of 91, 92 on 100% high flow, compared to another one who will be on ultra protective ventilation or protective ventilation, and see which one gets better earlier.
Okay, thank you, Dr. Shamsa. I don't have any more questions, so please, if you have any more questions, you can just type them and send them away. Anything that wasn't clear during the presentations or anything that you want us to expand on? Well, I'm pleased about the questions. People are starting to get involved more, and we like it when people ask questions. That means they were listening to us, first of all, and also that they are interested in the topic. So, and you're thinking also about the whole thing. So it's very good. Okay. I think we're almost 9:30, so we're doing well for time, considering that some of us took longer than usual. So I think we're going to conclude the session today. It's been great having you all, and thank you very much for attending the session on a Friday afternoon. Tomorrow we're going to carry on the same as today, starting at 4 o'clock, according to the schedule. Is that correct? Day 2. So yeah, 4 o'clock starting tomorrow with troubleshooting and complications with Dr. Bina Yusuf. So again, just go through what we've been through today. If you have any questions, you can ask them tomorrow about any of the topics today. I hope you enjoyed today and we're able to kind of make it a little bit more clear about the ECMO for those that, you know, didn't know much about it, and look forward to seeing you all tomorrow. Thank you very much. Thank you, Dr. Shamsan, Mustafa, and Tayyib.
Thank you very much. Thank you very much. Thanks.
Thank you.
Have a good night. Thank you.
Thank you. Good night, everyone.